system and LGBTQ acceptance here in the Philippines, as well as my experience in pushing for health system strengthening reforms in the DOH, and finally my aspirations to achieve recognition and acceptance for my community within and outside the health sector. So let me give you a brief overview of my presentation. The first part would be giving you a glance of LGBTQ plus acceptance here in the Philippines, as well as my identified problem statement. Next would be specifics of my project, my objectives, my theory of change, the stakeholders that I plan to engage with, and the activities that I plan to do with them, and of course, my deliverables. And lastly, my plans on how to carry this portfolio forward after the fellowship program here in the DOH, as well as my mission vision for LGBTQ health. So, global surveys estimate that almost 10% of populations identify as LGBTQ. So with the current population of the Philippines, we can say that there are around 11 million LGBTQ Filipinos. In the past decade, the Philippines, in global surveys, the Philippines actually ranked high in terms of um, being LGBTQ friendly. In 2013, we ranked 10th among 17 countries whose majority of their population think that the LGBTQ should be accepted. Recently, in 2020, we've also garnered a high score in terms of LGBTQ acceptance. But despite the positive survey results and the numbers that we have, our community continues to face violence and discrimination. The stories of Jennifer Laude, Ebeng Mayor, Mary Joy Anunuevo, and Donna Niera, LGBT individuals who were killed simply because they're LGBTQ. The story of Gretchen Diaz, a trans woman who got arrested for using a public women's restroom, and reports of LGBTQ individuals being denied of work simply because we're LGBTQ make us question if the Philippines is truly accepting of our community. In my years in the DOH, I've also witnessed the gaps in our health system that make us fail to promote the health of the LGBTQ. In the countless policies that I've reviewed, I've come to realize that there is a particular orientation of our health programs and services towards cisgenders and heterosexual individuals. Only the adolescent health program as well as the HIV and AIDS program have recognized the LGBTQ as a key population where their needs or health issues need to be addressed. And this is primarily because a lot of our health policymakers have not recognized sexual orientation, gender identity, and expression as a critical social determinant of health, therefore have limited understanding of the needs of the LGBTQ. Stigma and discrimination by health workers has also remained prevalent. And this is something closely personal to me because I've personally experienced discrimination when accessing a particular service, even as I am working in the DOH. I was once profiled as someone who is engaging in risky sexual behavior simply because I was a trans woman, not knowing my background and all of that. In one of the advocacies that I did, um, I've encountered LGBT individuals like me who have also faced discrimination within the health sector. A gay man I once had a conversation with a gay advocate, where he experienced discrimination from a doctor, and he was denied of an essential surgery simply because the doctor was afraid that he might contract HIV because the patient was gay. And lastly, as a trans woman who's medically transitioning here in the Philippines, I've also witnessed the lack of specialized or tailor-fitted care for LGBTQ individuals. When I started my medical transitioning, I primarily relied on referrals of my friends because I was afraid that when I come to an endocrinologist or a primary care provider and tell him or her that I want to undergo hormone replacement therapy, they'd simply tell me, I don't know what that is, or you shouldn't do that. It's going to be detrimental to your health, or it's going to be against my religion. But all of these things are actually just the tip of the iceberg. These are the things I've come to realize at my vantage point as a trans woman and also as a health policymaker within the DOH. Recognizing that LGBT individuals have different backgrounds and experiences compared to my own, I know that I need to take a deep dive with my community. As I started interviewing LGBT groups or civil society organizations, as well as LGBTQ individuals not part of these organizations, I've come to realize that their experiences are very different of my own. And I've learned a lot about how these different factors affected how they see their health and even how they see themselves as individuals deserving of the healthcare services that they need. So in order for me to address the various problems that my community faces when they are accessing health services, what I want to do is to develop a policy framework on the promotion of LGBTQ health in the Philippines. And I intend to do this by engaging with different members of my community, the different organizations that have been formed that have comprehensive experience in terms of pushing for LGBTQ rights, supporting the health of their members. I want to deepen my understanding of the complex health needs of LGBTQ Filipinos and their social determinants by engaging with these people and these groups. At the same time, since this is a policy framework, I need to engage with relevant DOH offices that will actually help me build the policy framework and carry out the work during and after the fellowship program. Recognizing also that there have been key experts who have been working on this for so long, portfolios on LGBTQ health, as well as portfolios on general LGBTQ rights. I want to I want to interview them and engage with them to get the wisdom on how to push this critical reform forward. So, recognizing that there are various problems encountered by LGBTQ Filipinos when accessing healthcare, my theory of change is focusing on the development of a policy framework through a participatory action project. This means that I will be engaging with a lot of stakeholders and individuals from my community, as well as the different offices in the DOH that will carry this portfolio forward with me. By being able to do this, I hope to increase the understanding of LGBTQ health within the DOH, actually starting the conversation on this. And by doing this, I hope that in effect, it will result in the development of further necessary policies, infrastructure, and capacities that promote LGBTQ health. And by being able to do or to develop these health systems building blocks, I hope that there will be provision of new or an improvement on how we provide health services to this particular community. And by being able to foster a very inclusive healthcare healthcare services, I hope to improve the health-seeking behavior of my community members and their subscription to the health system. And finally, in the long run, the goal is really just to achieve an LGBT inclusive and responsive health system. So as I mentioned earlier, the stakeholders that I plan to engage are primarily civil society organizations of LGBTQ civil society organizations, as well as individuals who aren't part of these organizations, especially those who have often been neglected by government actors and have not been included in discussions, like sex workers, hairdressers, drag queens, these key populations whose experiences, I believe, provide us with relevant inputs on how we can be able to address their healthcare needs. My second stakeholder would be DOH offices. Offices whose portfolio are centered on health promotion, policy, disease prevention and control, facility development, and human resource development. And others who will actually help me push this portfolio forward, and who I actually plan to provide that LGBTQ lens that our population is actually worth noticing, because we are also bona fide members of society, and our health services or our healthcare needs need to be addressed as well. And lastly, as I mentioned earlier, I also plan to engage with LGBTQ rights experts as well as LGBTQ health experts who have done the work in the recent or in the last decades and are still continuing to fight for LGBTQ rights and LGBTQ health in the Philippines. This isn't something that's new, and I believe that their expertise will pretty much help me pushing this portfolio forward within the Department of Health. As for my deliverables, the first thing would be a thematic analysis of LGBTQ needs from my interviews with individuals and civil society organizations, as well as the experts. Secondly, I hope to develop a technical working group for LGBTQ health with DOH offices and LGBTQ resource persons or groups, so that my work, the work that I'll be doing here in the fellowship program, will be sustained even after the fellowship program. And then lastly, my primary concrete output would be the policy framework on the promotion of LGBTQ health, developed with relevant stakeholders in the DOH, as well as with my community members. Post-fellowship, I really want to become an LGBTQ health champion within the DOH. Some opportunities that I've identified is the work of the Health Promotion Bureau. They will be implementing a fellowship program with an LGBTQ health portfolio, and I plan to have them as the policy owner of the policy framework that I intend to do with this fellowship program. There's also an opportunity for me to situate myself within the Disease Prevention and Control Bureau, who is working on portfolios like HIV, mental health, family planning, sexual health, all of these programs and services that are relevant to my community. And of course, there are bottlenecks to what I'm doing. A particular bottleneck that I've identified with my conversations with my colleagues in the DOH is a lack of basis for particular strategies to mobilize DOH offices. So this is something that I am aware of, and this is something that I intend to work on with my fellow DOH colleagues. And lastly, my mission is just to develop or to lead the development of gender transformative policies and infrastructure and human resource capacities, as well as the allocation of necessary resources to facilitate the provision of LGBTQ services. This fellowship is really just the start of a lifelong career, and I really see myself working on this portfolio until until the rest of my life. And finally, with the work that I'll be doing during the fellowship program and after it, I really hope to achieve an inclusive Philippine health system that responds to the needs of all Filipinos, regardless of sexual orientation, gender identity, and expression. Uh, this is my last slide. Thank you so much for listening, and I'm now open to questions. Thank you.
Great work. Everyone is able to get off mute now. We can give Martha a round of applause if you'd like. You guys can take yourselves off mute. Yeah, send those applauses. I'm going to now open it up to questions. First, let's start with the mentors. Anyone who is one of Martha's direct mentors or another mentor for the fellowship. Would love to see if you all have any questions for her. Take yourselves off mute if you have a question or a comment. Also opening it up to Mike and Nadia as part of the fellowship board. Feel free to chime in. Anyone else now opening it up to the bigger group?
I guess I'll just start by saying that I'm really impressed by the work you've been doing, and you've clearly outlined a way forward, and I think it's really important that you're starting with needs assessments before moving into the policy framework, and I'm excited to see what comes of the rest of this year.
So hi, hello, hello everyone. I'm Marife, and I'm one of the mentors of Martha. So perhaps just maybe to, of course, I already had sort of seen what Martha had presented, but maybe to ask Martha to share very, very quickly how truly diverse the LGBTQ community is, and how when you began, you didn't think that it would be very diverse, at least even in terms of putting together or identifying what would be certain specific health needs. Perhaps you can share to the body what you found out even with just the conversations you had with members of the LGBTQ community. Over to you, Martha.
Yeah, thank you for that question, Doc Marife. Yes, so in my short conversations, or with the few conversations that I had with civil society organizations and LGBTQ individuals, at first, coming into this fellowship program, um, in my head, I already need to implement a capacity building, implement, um, develop the policy, or um, introduce specialized health services for my community, because it's something that was an issue for me as a trans woman. But having interviewed other members from my community, intersex people who I didn't know, um, has a very huge problem with how doctors are providing services to them, because the expertise here in the Philippines is lacking. A lot of doctors don't know how to treat them, or worse, they've they were seen as medical anomalies or curiosities that have led to violations to their privacies. Or other conversations that I had in terms of why other trans people like me doesn't even see medical transitioning as an option, because or they even see it as impractical, because their their priority is to bring food and water to the table, satisfying their basic needs, is something that actually opened my eyes to and expanded my awareness of the different factors, that affect their health, how they see themselves within the health sector and within society in general. At first, I thought I just need to fix A, B, C of the health system. But when I actually started interviewing, I've come to realize that yes, I still need to focus on, or I still need to improve A, B, C, but a lot of the work is actually multi-sectoral. And so the interviews have actually helped me identify more comprehensive and better strategies. And I'm just really excited to actually hear more, because I've only interviewed trans individuals, intersex individuals, gay individuals, and I plan to interview other LGBTQ individuals and groups as well. So I'm just really excited to know more about their stories and hopefully develop the framework with them.
Great. All right. So in an effort of time, I'd love to get Nadine up and ready. Thank you so much to the mentors for obviously walking through this journey with Martha. And Martha, fantastic, fantastic presentation. Applause. Yes. So I'm going to leave everyone else since there's only like 20 something people on this call, I'm not going to necessarily put everyone on mute. So, when the presentations end, again, feel free to take yourself off mute to ask a question. During the presentations, I just ask that you stay on mute to respect the presenter. Nadine, whenever you're ready, please start sharing your screen.
Yes, I'm ready. All right, let me start sharing my screen.
Also, feel free to announce the country you all are from. Martha is from the Philippines, and Nadine is also from the Philippines.
All right. Sharing my screen. Yeah. Am I sharing my screen now? There. Is my can my screen be seen now?
Yes, we can see your screen. If you'd like to come off video, that would be great. Yes, great.
Yeah. There. I'm yeah. All right.
Yep,
So
we can see you.
good evening from our side of the world. Good morning, good afternoon to wherever you are. I'm so excited to be presenting this to everybody. Please forgive me for taking my time. My little boy was fussing. It's bedtime. So I'd like to present to you the Ugnayang Nanay. Ugnayang Nanay is a Filipino dialect which means motherhood connection. So I am hoping to create enabling breastfeeding communities through empowering and connecting empowered breastfeeding mothers and champions. And my presentation would be the introduction about breastfeeding. Breast is best, the problems breastfeeding mothers are facing, and the advocates, which I call the big letdown, the motherhood connection, and what its role is in addressing the problem, and hopefully the impact of this project would be. So they say breast is best. It sounds beautiful, but in reality, it is a very divisive statement, because mothers who are not able to breastfeed, would mean that they would carry on this guilt of not being able to give optimal feeding to their child. And so they say fed is best. But I would like to refute that. Fed is not best, because um, putting feeding rice water to a child is being fed, and that's not best. Feeding rice creamer to a child, that's fed, but that's not best. So breast is best, and that's a fact. No other opinion, feelings would change that, because breastfeeding is our biologic and physiologic norm. And that's why every child needs to get optimal breastfeeding starts. They said if a new vaccine was available and could prevent millions or more child deaths a year, it was cheap, it was safe, it was administered orally, and it required no cold chain, it would be an immediate public health imperative. Breastfeeding already does this and more. But why aren't we investing in it? Because it's not a commodity. It's not a commodity that you can profit from. And that is the downfall of our health system. Breastfeeding is a key life-saving intervention, both in crisis or not. If these recommendations were followed globally, we would prevent 823,000 deaths of children and deaths of 20,000 mothers from breast cancers, heart disease, and other non-communicable diseases. Just today, the Typhoon Rai or Typhoon Odette had a landfall in the Philippines, and it has been raging in the afternoon. And on my screen this afternoon, floods, stories of floods, landslides were everywhere. And seeing this on the news made me feel so worried for the children who are going to be affected by this. Is the government ready? Is the local government unit ready? Have they planned for infant and young child feeding in emergencies? I do not know. So the World Health Organization, UNICEF, unanimously recommends that breastfeeding should start early in the first hour of life. Babies below 6 months should only be taking in their mother's breast milk. And by the time that they are 6 months old, they should be eating healthy, whole, safe, and properly prepared complementary foods, and should continue up until 24 months of age and beyond. This is optimal infant and young child feeding that we want every child to have. But here comes the big letdown. In the Philippines, there are 180 babies born every minute. That means there are 1,403,336 live births in 2019. But among those, only 34.5 of those were able to exclusively breastfeed until the 6th month. Actually, the number that they are reporting is around 54%, but that's already the average from the 1st month until the 6th month. So they have a lapse in the numbers, which seems higher, but the real number is only 34.5%. And if babies needed to feed for 24 months, babies are only breastfed for 8 months. That means they miss the most important building blocks of their brain, which comes from their mother's breast milk. In the Philippines, we also suffer this silent tragedy. There are 250,000 children who have visible malnutrition. That means those are 250 children who you can see are severely wasted, who have acute malnutrition. But a silent tragedy down in everywhere is 28 million children with hidden hunger. That means there are 28 million children who are stunted and have undernourishment because of many factors. Not breastfeeding is a big factor to that. Poor nutrition, food insecurity would be one of the many reasons of why these 28 million children are silently dying and are cursed for life. And wouldn't it be, and it is so unfair for children to be facing these consequences of greed from milk companies and from our apathy to infant and young child feeding. We see promotion of breastfeeding everywhere. There's immense pressure for women to breastfeed. Everybody knows breast is best. Every mother would want to breastfeed their child. But when they have cracked nipples, sore nipples, who do they ask for? They're told, oh, that's normal. Or if they need to go back to work, juggling home, their careers, breastfeeding, who is there to support them? They will be left to fend for themselves. Why are mothers not being able to breastfeed? Is it because physically they can't? That's the biggest misconception that there is. Our bodies are not failing us, but it is our environments failing women all over the globe. So you see, breastfeeding is biological. It is something that mammals can do. But because we are humans, breastfeeding becomes behavioral, it becomes sociological, it becomes cultural. And therefore, our environment shapes our breastfeeding practices. So we perceive insufficient milk supply, we feel there's low milk supply because everyone around us tells us this. The marketing ploys of milk companies, pumps telling you that you have to pump early, and you see a very low milk output from using their device, and mothers just go, oh, I just can't, my body's failing me. So the failure of not being able to breastfeed is not just that. There's increased risk of child death and illnesses. Not breastfeeding means babies are at risk of diarrhea, pneumonia. Breastfeeding is the #1 prevention of deaths and illnesses at 13%. Vaccinations give 1% to 2% protection, but we roll out vaccinations, feeding programs, but how much do we invest in breastfeeding? The economic burden of artificial feeding is immense. Imagine each family spending $107 on infant formula. A minimum wage earner earns less than $1. Can only earn 500 pesos a day. So that's $10 a day. So if they're gonna spend that on infant formula, what's gonna be left for the food for the whole family? They spend 58% more on buying food for one child, which could be spent on education, and Filipino families do not have families of one child. There's 4, there's 5, and if there's one child who is who is fed with formula feeding, they cannot sustain it, and therefore they buy and use very suboptimal food like rice washings, coffee creamer, and mothers also. Then the lastly is mothers experience poor mental health and physical health. Failing to meet feeding goals would mean experience of grief, anger, and loss, and your body actually feels like you lost a baby because there's no one feeding from you, and there would be this increased stress hormones circulating around you, and there are imbalances of hormones which makes you more prone to cancers, diabetes, heart disease, and obesity. There are many breastfeeding advocates in the Philippines who have the heart for service. We even create innovative breastfeeding support programs. Just like in 2017, in an armed conflict, we were able to create an innovative infant and young child feeding in emergency response where we packed around 500 Malong Care packs, created 2 community kitchens, and provided an enabling environment, protective environment for breastfeeding for the evacuees in Marawi. We were stay-at-home moms, we were working moms, but the heart of these people were able to save children and were able to do things that the government wasn't able to do, something that international agencies couldn't do. But sadly, we are volunteers. We are left burned out, scrambling to deliver these services to help our mothers. We have trouble finding funding, women power, and frustrated with policy enforcement. Just like right now, during the Typhoon Odette, I'm thinking like, how am I going to help when even if we are also affected by the typhoon? So my question is, how can we capacitate champions to access funding, and we could synergize our efforts so that we can create a stronger voice in agenda setting and carry out this community advocacy efficiently and help more mothers and babies and protect them from predatory marketing and just enable them to reach their optimal feeding goals. And that's why I came up with a motherhood connection, because it is something that was why my advocacy happened, because we had this motherhood connection, a connection between 3 friends who shared the joys and struggles of motherhood, and we decided to share that to the community, so that bond of 3 mothers is now shared with thousands all over Mindanao, and we are now creating a social change within our communities. And we are the Modern Nanays of Mindanao. We are a support group of mothers on Facebook who come from different walks of life, and being part of the group would mean there are range of benefits on the platform where we can share experiences with each other, we exchange social support, which is very crucial in our transition into motherhood. There was even this one time that it was said that it is only in this forum where a mother who doesn't have a refrigerator can talk to a mother who is in the corporate world, who is a bank manager, and you get to experience these connections and communication exchanges between mothers from all walks of life, and you can see that breastfeeding is one of the greatest equalizer, and all children deserve to have this, and all mothers deserve to be supported and enabled to do this. So my vision would be to have mothers be in enabled and empowering breastfeeding communities. That means that community has a skilled network of breastfeeding leaders. There are established chains of breastfeeding support centers and localized laws and enabling policies. So through this community, each mother can meet their breastfeeding goals, and we can lay the best foundations of lifelong health to every child. How would I do that? by congregating and engaging these passionate breastfeeding leaders together and also stakeholders through innovative and collaborative organizational development programs. We need to build our capacities through capacity building trainings and strategic planning initiatives so that we can create this blueprint, a foundation on how do we make this enabling community. So how do I do that? How can the motherhood connection change the problem of society? There are mothers unable to meet their breastfeeding goals. Babies are dying. Mothers are unhealthy. Families carry this economic burden of artificial feeding. So we need to connect together, build the capacities, create an action, then we will see the change. When we connect champions of maternal and child for maternal and child health, and we identify our common passions and goals, and then we identify problems and needs, and we have a mutual understanding of what to do and have that commitment to create and build these enabling environments. That is what I want to focus on with this fellowship, connecting these mothers, starting this domino effect of bringing people together to work on this goal. Once we bring them together, then we create the capacity. We build the knowledge, the skills, the values. We create a blueprint. We create a master plan. Then we transfer best practices and knowledge to equally passionate advocates. Then when we're ready, we can create action of creating innovative, effective programs and projects with competence and empathy. Then we can scale this up and create it in different regions in the Philippines and Mindanao, where we can create breastfeeding support groups and centers, who then would be the ones lobbying for localized breastfeeding enabling environment ordinances and create more partnerships with stakeholders. Then we are going to be able to see the change that we want to see, where breastfeeding becomes a social norm. Breastfeeding advocacy becomes sustainable. Then each mother will have increased access to skilled breastfeeding support, and wherever they are, be they become an entrepreneur, a market vendor, a working mom, they are in breastfeeding friendly environments. And so we will see mothers practicing optimal infant and young child feeding practices. Babies become healthier, mothers become at their best selves, and then families have this economic empowerment from not having to feed their babies artificial milk. This is the enabling environment that I wish every mother could have in Mindanao and in the globe. This photo here is a group of mothers, the Mother Nanays of Mindanao, supporting each other online, offline, strangers who could be family. And then this is the Alima Mother Support Center, where mothers can get skilled breastfeeding help. And this is a counselor here in the city who is signing an ordinance to create a human milk bank with a lactation support center. This is what I dream every mother to have in her community. An enabling environment means a mother and child dyad is protected, breastfeeding is protected, promoted, and supported. When you mean protect, we need to implement laws and policies. There should be strong enforcement of the milk code. When we say promotion, it should be unbiased, it should be accurate. Misconceptions should not be the norm, but facts should be the norm. And when there are problems in breastfeeding, there should be skilled lactation management services that are accessible and affordable. And how do we do that? We create these localized enabling policies with the LGU, with the local government unit. We create breastfeeding support clinics, and we create a skilled network of breastfeeding advocates to start this whole process of building the enabling environment. Through the Samia Rose Tumo Fellowship, these are my goals: to convene these breastfeeding champions and steer them towards a common vision and strategic direction. I wish to improve our capacities and skills so that we can develop our organizations and can easily scale up the advocacy. We want to establish foundations, our systems of breastfeeding support to create, and by creating an operations manual, a training module, and lastly, we would really want to create rapport and trusting relationship with our various stakeholders. So our main stakeholders are our mothers, the core team of the Mother Nanays of Mindanao. We are also in communication with the different mother support groups in the Philippines and in Mindanao. We have identified one each region in Mindanao and many others in Luzon and Visayas. And of course, the breastfeeding mothers in the community. We have the government as our partners. We have our health institutions who deliver maternal and child support services, and then private organizations who are potential funders who can share individuals or institutions who can provide technical support, mentorship, and collaborations in the future. So what is the social impact of the motherhood connection? It means that we are providing every child with the healthiest starts in life. That means we are laying the best foundations of lifelong health for her child, which extends not only for the first 1,000 days, not only until their infancy and toddlerhood, but it will extend up until 2 generations. And it is proven that if we invest $1 in breastfeeding support, there is a return of investment of $16. Every mother and child diet would have optimal health and wellness. Each family will be relieved of the burden of purchasing artificial milk. And crossing my fingers, if this becomes successful, we could prevent 1.5% GDP loss from undernutrition, or $4.5 billion, which is lost yearly from poor nutrition. And we can, with a reduced demand for artificial milk, we could reduce carbon and water footprint from milk consumption. No mother needs to be alone. She needs to have breastfeeding as a social norm. She needs to have accessible skilled support, policies protecting her, enabling environments, whether in normal conditions and in crisis, and she has empowered peers of breastfeeding champions, and breastfeeding management becomes included in the health system. And that would mean there would be no mother left alone in her struggle to give the best starts in life for her child. So thank you so much for listening, and I hope that you join me in this journey to connect more mothers together. Thank you so much.
Great work. I'm going to open for 5 minutes to the mentors or anyone else who might have a question for Nadine.
Do we just speak? Hi, Nadine. Thank you so much for your presentation. It was beautiful, wonderful presentation, as was Martha's, but I'm just trying to, my lack of contact with Martha and her presentation is just because I don't know how to understand technology. So I had trouble like getting myself together with questions. But my question for you is, are there people who have Facebook and no refrigerators?
Yes, there are. The Philippines is a highly social media country who has very high social media usage. They have a smartphone, but they wouldn't have refrigerators in their homes. And that's possible.
Thank you.
Hi, Nadine. So Nadine is our second mentee here in the Philippines. Perhaps, Nadine, very, very quickly or succinctly, you can update the body about the progress in relation to the local ordinance that was passed in your city related to the human milk bank, because I know that the Mother Nanays had something to do with the passage of that local ordinance. So just very quickly and briefly, update the group about that. Thank you.
So early February, a counselor approached me asking what would it take to create a human milk bank. So I told them that creating a milk bank is easy, but creating a program for breastfeeding support and running the milk bank is the challenge. So right now that ordinance is passed and approved with a budget of around 8 million pesos, but it's only for the establishment of the facility. Sustaining it for the years to come after the 8 million is still a question, but the conversations between the different stakeholders would be starting by 2022. The COVID situation is already slowing down. Because of the COVID situation, we weren't really able to discuss much about the logistics or the other things about the milk bank, but it's already in paper, it's already passed by the council. And the next step for us is to really create this strong working relationship, because this is going to be community, government, and hospital, and there should be good communication between us, the stakeholders, because it's a hospital-based but community-run hospital milk bank. So the definition of our roles, our deliverables, each stakeholder for this milk bank and lactation center should be clear, so that we can really use it to its full advantage.
You.
Great. Thank you so much, Nadine. It was a splendid presentation. In the effort of time, I'm going to move on to Ruth next to be able to present. Ruth's from Kenya. And Ruth, whenever you're ready, please go ahead and start sharing your screen.
Okay. Yeah. Allow me to speak and have better communication quality. Sharing my screen. So, hello everyone. My name is Ruth Wagatua, the Samia Stumo Fellow from Naivasha, Kenya. And this is my Q1 project portfolio for defeating fluorosis. You're welcome. Here is the portfolio outline. I'll be presenting to you the mission and vision of the project. I will briefly introduce you to fluorosis, and then I will take you briefly through the problem statement of my project, the goals of this project, stakeholders, the research methodology I've used in this work, theory of change, the planned direct social impact intervention, and my project Gantt chart. The mission of this project is to bring healing empowerment to the people born and living in fluorosis-affected communities through activities that promote their well-being. The vision of this project is to make a lasting impact in fluorosis-affected communities through the implementation of sustainable public health infrastructure solutions that will enable universal, safe, and good quality water provision towards defeating fluorosis. So we were able to formulate this mission and vision in the month of September under the guidance of our project program manager and our in-country manager. Fluorosis is a condition caused by the consumption of water with high fluoride levels and presents itself in the form of dental fluorosis. This is the visible fluorosis presented here. So, oh, damn, sorry, I don't know where I've clicked. A moment. Sorry. So, like I was saying, so fluorosis, here we have dental fluorosis and skeletal fluorosis. And other cases of fluorosis are invisible fluorosis, such as lowering of IQ among children, and among other effects of fluoride, depending on the dosage of the fluoride consumed. And fluorosis does affect the most vulnerable groups the most, and they include expectant mothers. For myself, I got fluorosis through in utero exposure to fluoride. My mother consumed water with high fluoride when she was pregnant with me because it was the only readily available source of water for them. Then the other vulnerable group is children under the age of 8 years, because this is the bone formation age. And then the other vulnerable group is parents with young children, that is the caregivers. Myself, I have a son who's 8 years old, and I was so worried that he doesn't get back into this fluorosis cycle. So I was so concerned on the water I'm consuming when pregnant, and also how I'm taking care of him during these bone formation years. Then the other vulnerable group is the youth that are in the age-seeking bracket because they experience discrimination. I know 2 people who are eliminated from the amyloid recruitment process because of their brown teeth. I know people who've been denied front office jobs because of their brown teeth. Fluorosis has been prevalent in our communities due to lack of affordable defluoridation technology, the insufficient awareness on water safety, the health literacy when it comes to fluorosis is very low. Then high poverty rates. This is a disease that affects the poor, and the solutions are normally very expensive. Then the lack of water safety coping strategies, expensive dental and bone healthcare procedures, and the unevolving water and public health policies on fluorosis. And this cycle of challenges, as I have demonstrated here, continues. Naivasha, I'm going to show you where Naivasha is in the map of Kenya. So this is Kenya. Then we have Nakuru County in red. Then I've projected that, the Nakuru County map. And this is Naivasha in pink. So in Naivasha, data on the quality of water and documentation on the number of people affected by fluorosis, how fluorosis presents itself, and other diseases caused by high fluoride consumption is not readily available, and the local population do not have knowledge nor the nor control of the fluoride concentrations in the water they consume. This is because the water and public health information systems or surveys like population census do not capture this important indicator. Here are the goals of I partitioned the goals into 2. That is my personal goals for the fellowship and my project goals. So I hope to network with ThinkWell experts and my fellow Samia Strumo colleagues. I hope to learn from my fellow colleagues as I add value to their projects. And I hope to be mentored into a refined public health analyst. I hope to incubate a social enterprise. I hope to grow my skill sets. I hope to utilize the tools and inspirations provided to a maximum. And for the project goals, I hope to be equipped with funding proposal skills so that, and I also hope to conduct quarterly targeted public health education to the community. I hope to lobby for a healthcare plan that covers for managing living with fluorosis. and I hope to set up a social enterprise consultancy. On stakeholders, we did a stakeholder mapping exercise in October, and I was able to identify the population this project aims to support. I was able to identify other stakeholders with whom I may collaborate with, and I proposed their area of support and their contacts. Then we were taken through a stakeholder analysis exercise using the power interest grid as demonstrated here. I've demonstrated with some of the stakeholders I hope to collaborate with. And then I got to understand at what point of my fellowship I'm going to engage the stakeholders. Then the research methodology I've used in this work, I've been reviewing literature. I've used my observation. I've conducted the first public health education in the month of November. I have received technical guidance from several ThinkWell experts. Then through the sessions with our program manager and my in-country manager, I have developed my skills, my consulting skills through the pyramid principle exercise. Then I've improved my communication skills. We've been working on Miro, and this helped me to map out and see the outcome of this project very clearly. Then we've been equipped with pitching skills. QGIS have improved on my mapping skills. Then I have learned in-depth PowerPoint skills. I didn't know I could even come up with this kind of a presentation. So I'm very grateful, Mira. And then through the implementation research toolkit, I've been able to equip myself with funding proposal skills, and I'm developing proposals within this month of December. Then my theory of change. I have 4 strategies that under my theory of change, and they have been derived directly from my project goals. I hope to be equipped with funding proposal skills so that I'm able to develop funding proposals for rainwater harvesting tanks and water treatment plant, so that I can be able to reach out to potential project partners and pursue investment partnerships in order to gain leads into securing funding for these public health infrastructure solutions that I have proposed. And in the second strategy, I hope to conduct quarterly targeted public health education to the community so that I can create education spaces and for these platforms to be mediums for sharing fluorosis eradication wisdom, and so that I can give fluorosis affected human spaces to speak and heal. And I also hope to empower them with home policies that to ensure water safety. On the third strategy, I hope to lobby for the adaptation of healthcare financing into a primary healthcare that covers for dental and bone healthcare procedures, so that out-of-pocket expenditure on treating fluorosis can be minimized on. Normally, the procedures are very expensive. And I hope to push policy outcomes such as a healthcare financing scheme for fluorosis-affected humans towards evolving water and public health governance. And on the fourth strategy, I hope to set up a social enterprise consultancy. I've come up with the first name. I need 5 names. EMPAVOLVE. EMPAVOLVE means empower and evolve. I'm still thinking on the other 4 names. And I hope to register it so that we can be able to prevent as well as eradicate fluorosis from our communities, so that we can bring healing and empowerment to people born and living in fluorosis-affected communities through activities that promote their well-being. And this is the platform that I intend to sustain this work even beyond the fellowship year. The planned direct social impact intervention. So through the rainwater harvesting tanks, the project has the potential to reach approximately 1,000 households initially. And these are the people in the rural areas that are not connected to the county water supply grid. And through the water treatment plant that I've proposed, I hope the project has the potential to reach the whole population. But initially, it would first of all reach out to the people who are already in the water supply grid. Then through the dental and bone healthcare coverage that I hope to advocate for, the amount allocated to fluorosis treatment plan will be adequate. And I hope we'll be able to minimize on out-of-pocket expenditure when it comes to managing living with fluorosis. I hope to involve the following partners. I hope to involve the African Union. They sponsored me in my master's, and I'm sure they will be ready to support me through the implementation journey. I hope to approach the Ministry of Health, Water and Sanitation, the Ministry of Energy, and the different county departments of water, energy, and health. I hope to approach the Kenya Electricity Generating Company as the implementing partner for the water treatment plant. I hope to approach the Water Services Trust Fund. This is a channel established to channel external resources to water supply to the disadvantaged communities. So I will use this angle to approach them, and I hope to approach the Water Resources Authority. Then I hope to partner with the fluorosis affected communities, this population that this project aims to support, and then the local leadership. I hope to get support from the Thinkwell Institute project sponsors. I hope to get sponsorship from World Bank, UNICEF, UNESCO, USAID, Davis and Shartleaf through their Improving Lives program, World Vision. All these partners, I hope to approach them either for technical support or technical advice or financial support, and even banks, our local banks, through the activities that support community social responsibility. And I hope to approach Bill and Melinda Gates Foundation, Thomson Reuters, and Safaricom Foundation. So here is my project Gantt chart. The first month of September, we were taken through project ideation. Basically, we were refining our problem statement. We were refining our goals for the project. We formulated the mission and vision for the project. We listed our personal goals and the project goals, and we were able to make the project goals SMART. And then in the month of October, we were taken through stakeholder mapping, and we were able to develop our theory of change. And from the theory of change activity, I was able to come up with this Gantt chart, a clear work plan from where to work from. And then in the month of October also, I started equipping myself with funding proposal skills all the way to November. Then I'm developing the funding proposals within this month. Then I hope to be equipped with budgeting skills also in this month. Then we've worked on the blog posts. We were able to work on the blog posts, and we submitted them at the end of November. And I hope to reach out to the potential project partners between January and February. I hope to conduct quarterly targeted public health community education. As you can see, in the month of November, I conducted the first one. Then the second one, I'm hoping to conduct it in February, then May, then the last one in August. Then I hope to have developed my blog post for quarter 2 by February. I hope to set up social consultancy within the month. By the month of February, I hope to have registered it. I hope to be taken through business canvas model. I hope to be taken through in-depth elevator pitch skills in the month of April. I hope to lobby for the adaptation of healthcare financing between March and May. I hope to develop the blog post for quarter 3 between March and May also. I hope to reach out to the donors in June. I hope to develop the quarter 4 blog post between June and August. I hope to compile the final reports as from June, and I hope to execute a feedback presentation of the learnings and findings in August. And this project Gantt chart will evolve depending on our syllabus. As our syllabus evolves, also this work plan will also evolve. And we've come to the end of my Q1 portfolio presentation. Thank you so much for listening. So I'm open to questions.
Thank you. Opening it up to anyone who wants to get off mute and ask questions.
Thank you very much for that presentation. One of the things I liked a lot about it is that it oriented me clearly to the fellowship. So I could understand how the fellowship was clearly interacting with your development in each phase. I really, really appreciate that. I feel like I got like a tutorial on what is going on with the fellowship. And so thank you so much for that. I wanted to share an exercise that I did for radio announcing. So to get, if you would warm up before doing a run or something like that, kind of warm up your body. Everybody also needs to warm up their voice. And so a funny and very effective exercise is to stick out your tongue like that and read a paragraph with your tongue stuck out. Even if you only read a few sentences, one thing it's going to make you do is laugh, which is important to relax. Another thing, it will actually stretch your muscles and everything so that you can speak more without any tremor or anything like that. I tend to have a lot of tremors, so I'm conscious of trying to do these relaxation. So I want to pass that on to you guys. And I wanted to understand, what is GANTT? It was at the top of your chart. I don't know what that is.
Oh, Gantt chart. It's a work plan.
Oh, okay. Is that just something
Yes.
people know? GANTT is a work plan.
Nadia, I think
yes,
it's a type of creating a project management timeline. I think this guy called something Gantt might have created it. That's why it's called a Gantt chart, but don't quote me on that.
Oh, okay. Well, it was a small thing that was confusing. But otherwise, I really appreciate the presentation. Thank you so much.
And I believe Janet and Anne might be on. Would love to hear from either of you if you're able to speak.
Hi, everyone. First, I think, Ruth, you've really come a long way in terms of ideation and being able to articulate what you're doing. And I can't wait for the second quarter where we're going to the actual project management, when you begin to actualize your plans. Those are my comments for now. It's been great working with you. Thank you.
Anyone else? Great. Fantastic job, Ruth. Thank you so much for sharing. Would love to move on to Ulul next. Ulul, if you would like to go ahead and start sharing your screen. I know, just to let everyone know, her mentors are joining right now. I'm just going to ping them to ensure that they can fully hear her presentation. Okay, Ulul, whenever you are ready.
Okay, do you see my screen?
Yes, we can see your screen.
Okay, so I will start now. Thank you so much for having me here. Good evening from Indonesia, and good morning, afternoon, and in your time. And then I will share my projects. My name is Nuzul Putri. I'm a lecturer actually in my daily basis. I work in Faculty of Public Health in a university in Indonesia. And the logo that I put here is a research group that I start with my colleague, another young researchers in my school, and we try to have this research group to also become to contribute more on the community. So I will also tell you the story about this research group and the correlation with my project itself. Well, my project is titled Documenting the Evaluation of the Adjustment of Capitation Payment for Primary Healthcare Facilities under the JKN. JKN itself is National Health Insurance Indonesia. We have this in 2014. We start in 2014, and right now this is the huge social health insurance that cover most of the health costs for Indonesian population right now. So the outline of my presentation will be, I will start with introduction, why I choose to work in this issue and the gap that I see that I want to address through these projects. And I think the involved stakeholder that I want to also accommodate in this project. And also the fourth one is the theory of change that I propose to use, and the methodology, fellowship activities that I plan, and the progress for my Q1 activity in this fellowship. And the last things, I also want to introduce you with the research group that I manage. This is the introduction itself. Actually, as the youngest lecturers in my department, most of my students commonly see me just for having chit chat about their story, about what they have done with their study, their dream after they graduate from the faculty. And I know that there are so many stories that they don't want to work in the primary healthcare services. They choose to work in more fancy health facility that they think, such as like a hospital or like a international company, such as like that. So based on their story, I know that there is low motivation of the student to work in the primary healthcare services, and also their low intention of student to work in the remote area. And the other side that I also work in the research, I commonly see limited studies that work in the capitation payment for primary healthcare facility. That happened in the health education. It represent the inequality of the health workers living condition, actually, because when my student told me the story that they don't want to work in the primary healthcare services in Indonesia, mostly in the area, in the remote area of Indonesia. I know that this is because of the living infrastructure that not so equal in Indonesia. One of students said to me that they even go back, she has come from Papua, the eastern part of Indonesia, where most of the primary healthcare services in Papua are almost 43.8% only have one medical doctors, and rest of them they don't have any medical doctors. My student said to me that they don't want to go back to their home because it's more pleasure to work in Java Islands, and there are a lot more story about that. And at that time, I also reflect to what happened to me when I choose to start my career path 10 years ago, when I want to after I graduated from the health school, public health school in Indonesia. I really I apply for a job in the primary healthcare services in one of in one of national project that put a young public health in the primary healthcare services. But unfortunately, my parents say to me that it's better for you to stay in Java because we they not sure that there is a good living condition there. So that's why I should cancel my dream to have work in primary healthcare services. So that's why I become a researcher right now in Indonesia. So with the reflection of my story and what happened with my student right now, I say that there is a small progress in the equality of the living infrastructure for the health workers condition throughout Indonesia. Actually, we already have more than 13,000 islands, but we, even though they are not all of the island is populated, there is someone living there, but most of the activity only happens in the five majors island, and the huge part is in the Java island when everyone everything is suitable enough. And then that was happened in the health education system and also in health system itself. In 2014, like after before that, national health insurance that start by our government have protect more than 223 million people in Indonesia, and this very great program that can cover all of the health need in Indonesia. But unfortunately, there is a very huge issue there, the primary healthcare facility infrastructures and the issue of the health access when even there is a protection, a financial protection for everyone there, but the issue of the availability of the qualified primary healthcare services and the maldistribution of health workers in the remote area is still exists. So based on that, I try to more focus on the primary healthcare facility. When we see that the primary healthcare facility in Indonesia under the JKN, under the National Health Insurance, it is paid through a capitation payment, which means that the health facility will receive an amount of money based on the participant that based on the patient that registered in their health facility. So the BPJS Kesehatan, BPJS Kesehatan is the financing providers, the health insurance provider for the JKN. They will pay the health facility through the capitation payment. So the primary healthcare facility will only have a fixed amount each month, and they need to manage their patient, their participant, the JKN participant that registers in their facility to always keep healthy, and so that they will not reduce, they will not spend more their capitation only to treat the sick patient. So that's why it's very important to understand how the health facility itself could manage their capitation, and also in the end it could improve not only the quality of care but also the living condition of the health worker itself in the primary healthcare services. I think it's really related with the story of my student when I say that they don't want to go to the primary healthcare facility with the unequipped living condition. On the other hand, there is an opportunity to manage a capitation system to be more powerful for the primary healthcare services itself. So the gap that I want to propose is how can we ensure that the modification and adjustment of the capitation payment under the GKN has accommodated the appropriate incentives and compensation for primary healthcare facility to able to serve people with different healthcare needs under the GKN. That was the problem statement that I want to address through these projects. And then by exercise the stakeholder analysis during the class in this fellowship, I can group the stakeholder into 4 groups that through list all of the stakeholders, and I know that their influence and the interest of the capitation payment itself. We see that through this figure that the BPJS Kesehatan is a stakeholder that must be kept satisfied with the evaluation, with the capitation payment, and there also the actively engaged stakeholders that must be also address their needs during this during the capitation evaluation. We know like the Association of a Primary Healthcare Facility, the District Health Office that manages the Puskesmas. Puskesmas is the one of the primary healthcare facility owned by the government, and its number is the huge one, and they are situated throughout the country. And then I also group that there is an association related to the health profession, like the Association of Medical Doctors, Dentists, Public Health, and the association that represent the health workers to always keep informed about the evaluation of the capitation itself. So this is the theory of change that I propose for these projects. I could divide it into strategies, short-term outcomes, and the long-term goals. My strategy, there are 2 strategies that I plan to do is that first, I need to document the result of the evaluation of the adjustment of the capitation payment. Like I have told before, that there is still a limited number of studies that evaluate technically about how the capitation payment formula, how the rate of the capitation already fulfill the needs of the primary healthcare facility in managing their works in daily. And then through after I document the evaluation, I will try to communicate the result of the evaluation to all of the stakeholders. I choose to use like the more reachable media, such as like blog posts that contain the evaluation that I have do previously in the another strategies to reach more audience in this stakeholders things that I already told before. So I hope that by communicating this result, the study result, it will increase the awareness of studying capitation payment under the GKN. So there are more people will know what is the problem under the capitation and what they should do with that. And I also hope that there will be a productive communication between stakeholders, because they already have a clear description about what happened in the field, and in the end in the short-term outcomes, there will be co-design policy recommendation between stakeholders related to the capitation. And I hope that I could empower primary healthcare facility to have information regarding the risk that they manage under the capitation itself. And in the longer term, so when we already have the risk, that we already have a recommendation about the capitation payment and what they should design on the risk that they manage. It will be improve the ability of primary healthcare facility in serving the different needs of healthcare of their patient, and also in the end there will be there are more young health workers that will be attracted to work in the primary healthcare facility in remote area. Maybe I should step back for the some like terminology that I commonly use here, like the capitation. Like I've told before, that capitation is amount of number of money that paid by the health insurance provider. This in this case is the BPJS Kesehatan for the primary healthcare facility in daily month. So the primary healthcare facility will receive some money, a fixed amount of money according to the number of the participants in their health facility. When we talk about the capitation, it must be like it should be have to based on the risk that managed by the health facility itself. The risk it means that when the younger patient will be the younger people will be have less opportunity to be sick, so it won't be cost more money of the capitation, but the older one will have uh, possibility to be sick in the future. So the health primary healthcare facility will have to more concern to work with the patient. And the other one, like women's and men will have different kinds of disease, so it must be also risk that also managed by the primary healthcare facility. That was in the basic concept of the capitation itself. But in the other side, in Indonesia, the capitation is based on the number of health workers that located in the that affiliated in the primary healthcare services. It not count based on the risk that managed by the primary healthcare services. So there is a great gap there that can harm the primary healthcare facility to cost more on the capitation payment that they receive from the BPJS Kesehatan. So that is the things that I want to answer through these projects. So the methodology that I plan to conduct is like I divide it into 1 year, 2 terms of time, like during the fellowship and after the fellowship, because I know that it could not be finished and it could finish in short term. So in 1 year fellowship, I try to use 3 stage. Like first one is I want to reflect what is the real capitation problems in the primary healthcare facility, and then after I reflect and identify the problems through this I will document the list of the problems, what the all stakeholder contribute to these problems, and how they will react to this. And then the last stage is I would like to share the evaluation that I already conduct in the first stage and the second stage. That was plan. That was the activity that I will plan to conduct in during 1 year fellowship. And after the fellowship, I hope that I still make the review of the capitation payment is a main issue that we will bring in the our research group. The research group that I manage is the Airlangga Center Health Policy. It's called Aceh Health Research Group. I established it I started in 2018 with the other young researchers in my university, because we are not, we don't have yet any big research group before. So we started with this small research group, and we hope that we have vision that we also can contribute to the field, not only as a researcher that conduct research for their academic things. After the fellowship, I hope that this project could also generate a research roadmap for my research group, and then we also can have try to propose some proposal funding for research that we already identified previously. And the last one, the most ambitious one, is I think that I really want to encourage my research group to have a mass online open course for everyone related to decapitation itself. I think it's very really helpful, not only for my student but also the other health workers in the. This is the detail of the fellowship activity during the first one. I think the first quarter, I work a lot with reading the concept of the capitation. My mentors helped me a lot for me to understand what is the capitation and what should be the capitation in the futures. And then in the second quarter, I hope that there will be. I try to communicate what I have learned in the first quarter through the sum of blog posts, working with the association, working with the BPJS Kesehatan, and then in the third quarter, I hope I also have papers regarding what I already conduct during this fellowship, and the last quarter, I hope that I will have a sustainability plan for my research group to conduct this project in the future. So I hope that there will be a research roadmap that I will produce, and a proposal drafting for more funding opportunity. Then, yeah, the deliverable things that I think the most important is also a series of blog posts that I will manage in the second quarter to the end of this fourth quarter. This is the progress that I have made during the first quarter. I already learned about what is the basic concept of decapitation. I do a literature review, and then I know some finding there's like the difference concept between the difference between the basic concept of the capitation and the implementation in the National Health Insurance Indonesia, and I have a follow up plan for this. I will communicate with the BPJS Kesehatan. This morning I met them, and they really grateful that we can work together to learn about decapitation. And I also work with the association to understand what happened in the field, what the primary healthcare supervisors understand about decapitation. And I also have regulation readings. I read a lot about the regulation. I make a map about the regulation related capitation under the GKN, and then the procedure of the capitation payment itself. So I found some findings such as like the regulation of the capitation, the rate of the capitation have never been reviewed since 2014. And then the other one is related to the PCARE, the health information for the primary healthcare facility was not functional enough to support the health facility to manage the reach in their health facility. Then the last one that I also have conduct is like country comparison. I start with to learn what other countries have conduct with capitation, how they implement their capitation, the design, and etc. That was my progress for the quarter one, and I'm right now is finishing to finalize the draft of what I already document through the literature review. This is the last slide. I think this is the vision and mission of my research group. Our vision is to preparing stronger health system through open science. We really embrace the open science to embrace more population to know about the usefulness of the science in the health financing. And then our mission is also consists of 3 things: documenting the fact. We commonly work with study research, and then we not only study, but we hope that we can also share the lesson learned. And the end, we hope that we also can advocate for policy recommendation. That is the vision of mission of a really new starting research group that I manage with the other colleagues in my university. Thank you so much for your attention.
Fantastic work, Ulul. I'm opening it up to your mentors or anyone else who'd like to ask questions.
Thank you, Mira. Good luck. We call it Ulul. The nickname is Ulul here. Thank you. Great work. I'm glad that you made a progress in reviewing, understanding better of the capitation concept and adjusted capitation. However, I think the review of this will be better if you also touch one of the concerns about the capitation, which is normally people concerns of quality of services when healthcare provider are paid on capitation because of the incentive to make more money or profit by healthcare providers. They might sacrifice the quality. How do you tackle that concern to ensure that providers that are paid on capitation will still deliver quality of services? Have you reviewed some of the document provide evidence that quality of services remains the same, high, or really sacrificed in some cases, in some areas, for example? Thank you, over.
Yeah, thank you, Prof. Actually, I'm working on it, but it's still work on the how the health facility conduct the health programs as a public concern. It's not on not specifically to the private treatment for the patient, but during the discussion with the association, I know that they are the healthcare facility commonly not conduct like health programs appropriately for that address the health needs in the population. But I do not yet talk about the quality of care, but I will do after this. Thank you so much, Prof.
Thank you so much, Zulu, for your presentation. I thought it was very informative. It's a tough topic, I think, to explain to people. You did a good job. But I wanted to ask you more about, I don't know how to say it, but the Health Policy Research Group, ACEHAP. This is like a group that you're part of, I guess, and this work that you're doing with the fellowship is going to feed into the mission of this group. I might not be understanding correctly. Can you explain the relationship and what you're doing? So you're working for the university as a professor, and you're working with this group to promote health policy, good health policy.
Yeah.
Can you say a little bit more? Thank you.
Yeah, well, I'm working as a lecturer in Faculty of Public Health, so there are so many interests of research interests in the Faculty of Public Health, and a research group is a group of researchers that have a common interest in the terms in ACEHAP, Airlangga centers that I manage they focus on the health policy research, and I think it's very early research group, because I started in 2018 with my colleague that also a very young and very early career researcher. So it consists of so many early career researchers, and we commonly work with our student for in the bachelor's and the master degree that they want to conduct a research. We learn together in this research group. So in this fellowship, I work with them actually. So like I learned them about what I have learned during the class in these last 3 months. Like I teach them like the student actually about what is GIS, what is the stakeholder analysis, kind of like that. So I hope that after we have like the research roadmap and we know what exactly the problems, we will have a strong foundation to start this research group to learn or to try to have a funding proposal for this issue.
Okay, I just want to be clear. Is this a nonprofit? Is this an NGO separate from the university? Is it, or is it informal?
It is actually not in. This is formal. This is like more specific. Like I've said before, this is non-profit, because the goal is that researchers with common interests will have their media to work together and also to learn together, and also share to the younger ones. So like this is kind of like communication media or kind of like that, work together to develop all of people that join that research group.
Okay, thank you so much for explaining. And I think I have so many questions of each fellow, but I wrote them down, and I'm hoping that sometime I can talk to you guys about all these specific things. So thanks a lot.
Thank you so much.
In the new year, we can invite you in, Nadia, for a conversation again with the fellows. And I just wanted to point out, to everyone before I play Rukshan's presentation. First off, Rukshan's presentation will be about 15 minutes. So if folks can stay on for another, 15 minutes past the slotted time, that'd be great. But in terms of what the fellows' goals are during this fellowship, they have a very, very technical skill that they're working on, whether that is capitation analysis, whether that is policy writing, whether that is creating community education tools, or whether that is, creating a social enterprise. There's some technical side of it, but there's also this futuristic look on how are you going to house this work. And that's why I really challenged, especially for Ulul's, her work is so research focused, and this is a very, very technical concept. I challenged her to think about how would you want to house this in the future. And she spoke about this research group that she kind of started initially, and I was like, let's work on that. Let's expand it, and let's think about how you can use some of the tools in the fellowship to make this your own and to really, really have it be a standalone, organization of your own and in the future. So just to let you all know, there are these dualistic goals that each fellow is working on. And now I am going to play Rukshan's video. Rukshan is from Bangladesh. Unfortunately, she wasn't able to join us today, but we recorded her presentation. So give me 1 second as I navigate my technology here. Oh, wait, I am going to fix that because I need to include computer sound. I'm going to play it, and if someone can give me a message in the chat that they could hear, that would be great.
Okay. So hello everyone. I'm Rukshan Fahmi, and I'm one of the fellow from Samia Stumo Fellowship Program. And thanks to Nadia, Mike, because of them, I can develop a small project of making and developing behavioral change communication materials for parents who have hydrocephalic children. So I have made a small presentation for that, which I want to share with you today. Just a small introduction. What is hydrocephalus? So we all have brains, right? So inside our brain, there are fluids that are continuously taking paths. So when the pathway inside the central nervous system gets blocked, so what happens next? The fluid gets accumulated and it creates pressure in your nervous system. And when it cannot get out, it certainly enlarges your head circumference. So this condition is known as hydrocephalus. You can see the picture of the baby that the pain it is going through. And of course, as it's hitting the nervous system, if you don't treat it, it will lead you to disability and to death, and eventually to death. So when it comes to the scenario of Bangladesh, unfortunately, there are so few studies that there are no prevalence rate and very few numeric studies and almost no exploratory studies. By exploratory, I mean the studies that in-depthly that interviews the participants or the experiences of parents. How do they feel and what are their needs? So when I was exploring the numerics, very few of those numeric studies, I understood that the victims or the cases and of this, the babies of hydrocephalic babies are mostly from poor socioeconomic background. So as I didn't find any exploratory studies, I decided to conduct a few informal interviews, nothing some formal, but just a few informal interviews. And for that, I talked to a pediatric neurosurgeon who specializes in operating hydrocephalic babies. So as she said, that majority of the cases arrive here late. At first, they go to local healers. When they fail to help and the head keeps enlarging, the parents approach the pediatricians at tertiary level hospitals. But rarely they are referred to the neurosurgeons timely. Sometimes they try to operate themselves and end up with unsuccessful result because that's not their area of expertise. But most of the refer cases comes to us in this stage. So what happens? They're coming late. As a result, it increases their risk. So alongside, I was lucky that day because I came across a mother with a hydrocephalic baby. The baby was just operated. So I was talking to the mother and got to know this from her that we didn't know what to do. At first, we went to the local hospital, but for 2 months, there was no progress. So my husband searched in the internet and learned about a successful case operated in this hospital under that very neurosurgery department. So therefore, we came here. So that was her reaction. But you see, they had waited for 2 months and they were uncertain at that period. So it's sort of late. So that's when I thought that, okay, I am thinking of creating behavioral change communication materials for parents with hydrocephalic babies in Bangladesh. Maybe a useful way to investigate through research. So I know many of us are not from the same background. Even a few months ago, I myself didn't know what was behavioral change communication meant. So it is an approach to promote healthy behavior that uses an in-depth understanding of people's behavior to design persuasive communication. Like if you want to pursue someone, you have to understand their thoughts and other norms and other social determinants that makes up their habits. So behavioral change communication is that approach that can assist me to do that and do so. Come to my vision. My vision is every parent whose children have started showcasing the symptoms of hydrocephalus will get acquainted with my proposed BCC materials. And for that, I intend to develop standard BCC materials that addresses the needs of the target population. And my goals are to conduct initial formative research to understand the needs of the target group. By target group, I mean to say parents of hydrocephalic children. And then I'll pilot the draft message developed from the formative research among the target population and of course the community members, because at the end of the day, we are nobody without our community. And then we will again repeat the formative research. Here's the thing, within the first time, you can never understand that if it is the main message, you have to go there repeatedly. After a repeated or our number of series of research, then you can come to a point when you can say, maybe this message will be helpful for others. So repeating the formative research among other related groups to finalize the contents for BCC material. Then I will design a draft, of course, not the final product. Then I'll design a draft of the communication material with the aid of the relevant experts. As you know, I'm a public health personnel, but I am not an expert of this, so I need their assistance. And here are my stakeholders. So it's, as you see, that here are the ones with very high power, but low interest. It's not that they don't care about this, but the ministry has a lot of its plate. Like, think about COVID now. This is the current situation. So they have interest, but low, but they have the power to change it. Just like Director General of Health Services in Bangladesh, UNICEF, and Save the Children. But among these organizations are some tertiary level hospitals of Bangladesh, like National Institute of Neuroscience, Dhaka Medical College, Bangabandhu Sheikh Mujibur Rahman Mujib Medical University Hospital, and Dhaka Shishu Hospital. They're the top level, tertiary level hospitals of Bangladesh, and they have high interest and high power. Not only their interest, but they have the power to mobilize my target groups. And of course, there is the community. They have low interest and low power. They don't have the power, of course, to mobilize, but they have low interest because it's not a very common disease. It's a rare one, and you cannot just blame them for not being so serious about it. And when it comes to high interest and low power, there is this Hydrocephalic Society of Bangladesh, a doctors association. Yes, they might have high interest, but they don't have non-power, and it needs a lot of itineraries to implement. So they need support. And of course, last but not the least, the parents of hydrocephalic babies. They're the most interested personals in this whole stakeholder, among all the stakeholders, but they have very low power to mobilize. So that's why we intend to do something for them. And how I'm going to do it? Through my research methodology, I will conduct formative research and develop communication messages through in-depth interviews, one-to-one interviews, trying to dig up as much information as I can, and focus group discussions. If I can, I will try to have a focus group discussion with my target groups and of course the community members. Then I will pilot messages among the community target groups and community members, and then I will see that if the messages are how much is accepted among the target groups and community members. So here is my theory of change. What is my input? I will allocate time and budget to prepare the materials like interview guidelines to conduct formative research among my target group. It takes some time. Like I need to sit and have allocate a budget to prepare for it. And then my target group is not easy to reach as this is not quite common. So I need to approach physicians on those who are treating these patients at tertiary level hospitals, because that is the most frequent place I hope to see them to reach this target population. And then I will do some activities like conducting formative research by relying on qualitative methods like IDIs, FGDs. And then when I finish my interviews at FGDs, I will do the analysis. From that, I'll pick up the desired messages and preferred mode of communication. And then again, I will go do it. Because after repeated repeated series of researches, maybe I will come to a point when I will truly start understanding what their actual need is. As a result, output, I mean to say, I will acquire content of the messages to communicate with the target groups. And my outcome will be developing a draft of BCC material, not the whole BCC material, because it's a long way to go. So here's the short-term impact. I will initiate a process of developing awareness-raising materials against hydrocephalus, because I cannot just think that, okay, within a day it will change the world. At least it's a start. And this start can have a long-lasting impact if we keep trying and pushing hard. And the long-term impact, I'm not sure it can be seen, sorry, button. I hope that it will increase awareness among parents with hydrocephalus children, especially those whose children have started showcasing the symptoms. So they don't keep wandering around from this hospital to these local healers. They can straight go to the places they should be visiting from the very first symptom, from the very first moment. So the social impact of intervention, a draft of the BCC material can act as a start point to continue and conduct such type of interventions in the future to increase awareness among parents, because a draft of BCC material is not like, okay, I made this draft and it's finished over here. There will be documents and my experiences and many other things that can help those who aspire to make such materials in the future, not only for hydrocephalus, but for anything. I'm going to share whatever I learn over here with everyone. That's what I hope. Dhanyabad, we say in Bangla, it's thank you in Bangla language. Thank you, everyone.
Great job, Rukshan. I would like to now open it up to questions. I would love to start with your mentor, Shamima, to just ask you a few questions at this moment.
Thank you, Mira, and thank you, Rukshan. Like, this is a wonderful job. And I'm really happy to see that within this 3 months period only, you came along like so much. That's a like wonderful thing to see. And also, like I'm very like impressed and amazed to see that how your learning process coming along together in a and shaping it in a good way for a like good project that you are aiming to have. So that's really like great to see, and and it is really a good like feeling to be part of this process. So regarding this presentation, like I'm just starting from the beginning. Is like you are talking about hydrocephalic patients. So when you talk about like a research methodology that you are going to do in-depth interviews and focus group discussions, so do you have a like identified a specific way how to reach this special group of population who are not very common and who are not could be identified in so easily? So that one would be crucial, because that will also shape up your target group in an alternative way, that what target group you can work with. And the second question I would like to ask about the stakeholder analysis that you did. One like two criteria that you considered for this stakeholder analysis is how interested they are and how much power they have for this type of activity. So my question is like, do you develop this like stakeholder analysis considering the research activity or the implementation part of the process, that when they will implement this awareness materials? Because if we consider research part, the stakeholders will be a little bit different than the implementation part. So here you have a mix of like both group. So I want to be a little bit more clear about your considered stakeholder groups. And the third question I would like to ask you about the theory of change. The theory of change, it seemed to me that you might need to work a little bit more on this, just to be very definite about what is your input and for your outcome that you are expecting. output and outcome, whether you need like more inputs and more activities to consider, like to bring that outcome in a good way, in a successful way. So that's need to be like think about a little bit more, and also like bring the consistency, how what I want and what I am doing, to bring that consistency in that process, procedural consistency. That will be really helpful for you also to design your project, like the whole project. So I think, like Mira, I will stop here. This is the three main points that I would like to ask, and over to you, Mira.
Great. I would love to hear Rukshan answer some of those, so I'll give you the opportunity to do that right now.
Okay, thank you, Appa. Thank you, Mira. First of all, as for my in-depth conducting interviews with my target group, I intend to go to the tertiary level hospitals of Bangladesh, as I have mentioned here, National Institute of Neuroscience and Hospital, because that is the most common place that these patients usually end up going there after they go to the local hospitals and other places. But this is the final sort of destination. So here, and they also have this register book. So I hope that maybe I can come across with some parents of these patients who has come for treatment or regularly frequent for treatment. So, and these are the most common, and these places are for the similar, and these are the places where I can find similar cases of children. And Dhaka Shishu Hospital is another hospital. Of course, as a children hospital, definitely people will go there. So I intend to go to these hospitals to find this population, because that is the most common destination. They usually meet each other. And as for the stakeholder question, yeah, I actually organized it more from an implementation perspective, like those who have the capability to implement it, those who have the power. So that's what I was thinking when I arranged this stakeholder analysis. And as for the theory of change, as for my inputs, yes, I was thinking about involving community, but I still need to work my way out, because I need to be more organized about it, planning about it to address this comment on and involving community, because I have been thinking about conducting FGDs and ideas and small researches over there. So yes, I should have included the community members' perspective over here about getting involved with the community, as it has great impact over my outcome and output. So thank you for the comment, Appa. I will be careful about it.
Great. I'm going to stop there and open it up to anyone else who might have questions for Rukshan. I know she's not here, but I'm happy to pass them on to her if need be.
Well, and thank you, Mira, and thank you, Rukshan, and all her mentors. It's really amazing to see the whole development of this. And Rukshan, I'm sure you could look at the video or the recording of this. So this is like a quite fundamental issue that just came up here. We funded Rukshan to work on prevention of hydrocephalus, and she is working on coping with hydrocephalus. This is a big difference. And I knew that there were issues about trying to refine the project and trying to make sure it was based on reality and people's conditions and scientific knowledge, but to fundamentally change the direction of the project without checking with the people who were who made the decisions about funding for prevention rather than helping families cope. That's a huge difference. So I think this does happen with funders and projects, on the ground, you kind of get going and you kind of go off in directions which seem to make sense and seem to work. But it's, I think it's something super important for everyone to consider, being in touch with the intention of how the money was going to be used. So hopefully that's something that we can talk about, although at this point it's in half of the year, so I don't know what can actually be done, but I did want to bring it up. So thank you very much.
And just to react to that real fast, I wouldn't necessarily worry that the idea of prevention is not going to be mentioned. It's a conversation I would love for us all to have as a board with the mentors to get a better understanding. I think Shamima has probably directed Rukshan in a way where she understands the scope of the situation first, and that there's a variety of both preventative as well as actual dealing with the situation of hydrocephalus in terms of communication skills that she needs to develop. But she's in the research phase right now. She's not necessarily in designing her communication strategy yet. So when we get there, I will definitely flag this as, we want to make sure that there are these initial intentions that we had when we brought her on to the fellowship. But I wouldn't really I would say this is quarter one. There's 3 more quarters to go, so we can continue to check in. But thank you for that feedback. Other than that, we are pretty much closing up here. Thank you all for staying overtime to listen to all of the presentations. A huge thank you to every fellow who presented. You've made so much progress, immense progress, and you should be very proud of yourselves. On that note, unless anyone else wants to say anything, we will part our ways. Have a fantastic rest of your day, everyone. Talk soon.
Thank you so much, everybody. Thank you, Mira.
Bye, everyone.
Goodbye.
Bye, Mira.
Bye.
Thank you for your time, everybody. Good night. Bye.